everyone who's joined the webinar today. I think we will go ahead and get started while people are still joining up. So my name is Kate, and I work for Quality Core on the Patient-Centered Primary Care Institute, and we are presenting a webinar today on using data and quality improvement. Before we get started, there's a couple logistical things that we want to go through. First of all, everyone who is on the line today is on mute, so there are a lot of participants, and then to avoid accidents where we hear people's hold music or dogs barking, everyone is on mute today. But we would still love to hear people's questions, so there's a question pane in the GoToWebinar control panel where you can type your questions. I will receive those, and then we'll take a break at the end to answer some of your questions. You don't need to wait till the end of the webinar, though, to ask your questions. Feel free to go ahead and type those as they come up, and I'll organize them and have them ready to go when we get to a break in the presentation where we can address those questions. Before I turn things over to our presenter today, just again about the Patient-Centered Primary Care Institute, launched last year as a public-private partnership between the Oregon Health Authority, the Northwest Health Foundation, and Quality Core to offer a broad array of technical assistance to practices that are at various stages of transformation. So we have practices engaged in learning collaboratives with technical assistance providers. We have a website which it's likely that many of you have visited if you're on the webinar today, because webinar registration runs through the website. And we're working on some online learning modules that will be available later this year. And the goal is to really create an ongoing mechanism to support transformation among primary care practices in Oregon. So as I mentioned, we work closely with the Oregon Health Authority's PCPCH program. A little bit about the PCPCH model of care is on the slide, the core attributes of the model. There are specific standards and measures that practices attest to become recognized as a primary care home by the state. And you can read more information about the program, about the standards on the program website, which is listed at the bottom of the slide. And without further ado, I'm going to hand things over to Lori from the Oregon Primary Care Association, who is going to share some wonderful information with us about quality improvement and building a culture around quality improvement. Take it away, Lori. If you're talking to us, you might be on mute.
Sorry, thank you. I just did a long welcome. Hi, everyone. This is Lori, and I'm glad to be with you today. This is a really fun subject matter for me, using data in quality, and it's also, as all of you on the phone already know, it's very broad and very deep. So this is going to be a survey course with an emphasis on the exciting, early, confusing part of using data in quality improvement. For those of you that are further along in that continuum, there will be plenty of references to how to tie it into the bigger picture, the vision, organizational goals, and next steps in that path. Kate, did you turn over control to me?
I did. So if you click, you should be able to move ahead.
Yeah. I'm doing that. Let's see. We'll try again. There we go. So today the objectives are those three that you see listed. Look at various levels of quality data. Consider where real improvement can occur, which is where the rubber meets the road, and different tools that can be used at that time. And then explore the role that culture plays in an organization, a learning organization. Culture can either make or break you as you do improvement. This is the outline of what you guys are going to hear, what we're going to discuss together. And I just let you know how many slides in each area, because it helps me think of how I want to orient the conversation and helps you hopefully understand why the focus is where it is. So the first bunch of slides will talk about data, where it lives, different levels of data, and that will take us into using data for improvement and how we move down to the level where change can occur. And then how to build a culture of change and improvement that can support the use of data. What we know too well, and you guys probably know as well as I, that you really can't improve significantly in a culture that doesn't use data, and you can't improve significantly without data within the culture. So you really need both coming together. And another thing to remember is that it's never going to be perfect. I think all of us love to have things really outstanding, and we aim for that, but data is never flawless. Culture is never quite where we want it to be, and so we're always striving to improve. And this reiterates that top bullet, getting better problems. I've always liked that concept. So we're never going to be without problems in our clinics. The idea is that we're moving from some basic problems such as needing to hire a physician, needing to bring a patient in the door, needing to bill for a visit, to wanting to prove our hypertension control, to wanting to have high levels of staff engagement, to wanting to have high levels of patient engagement. So those are better problems. The basic ones are where we start, and then we keep moving along that continuum. And then below the second bullet is the use of strategic data. It occurs at all levels. So it's how you achieve your organizational goals. It's how you move to the level of the work. The critical few, that arrow suggests that you don't want to overmeasure. A lot of us want to know more and more. I'm one of those people. And if we do that to the staff with which we work, they end up being overwhelmed and not succeeding. So we want to really think about the critical few areas that we want to measure. The constancy of purpose speaks to us not losing focus in leadership and helping the staff members who are doing the measurement remain focused. We'll talk about cascading connections in just a little bit. And we'll talk a lot about culture and supportive conversations and how important those are. Data is really useless in an environment where people live in fear of what the numbers will show. And final arrow is really set up. If you're in a leadership or management position in your organization, think about how to help the team you put together succeed. That's your job, to really set them up for success so that when they receive data and start to make changes, they actually improve. I wanted to include this one slide, and it's sort of a lengthy slide, because I think that sometimes when we are in webinars, we think the people on the other side really know their stuff. And as I said, it's really a matter of always getting better problems. I was fortunate to be able to start a community health center about 15 years ago. And I had started a couple small programs in prevention and wellness prior to that, cardiac rehab, but I really didn't know what I was doing. And so I was the first employee of an organization that grew to have 120 people by the time I left. And I had those early problems of trying to figure out how to hire people and how to bring patients in the door. But pretty early on, within about a year, I realized, along with the staff members who had joined me, that we had no idea if we were making a difference in the lives of the people that we were beginning to serve. And we started wondering how to understand whether the patients, for instance, who were diabetics were improving or not. We knew we were seeing them, but we didn't know if anything was changing for the better. And so that's, where some of you are. It's just beginning to figure out if we're making a difference. We know that healthcare can't completely increase health and wellness, but we know that it has a role. And this was well before team-based care. So we were just talking about, patients seeing doctors really was a very elementary way of understanding this. And finally, we started to get Excel spreadsheets that showed A1Cs, hemoglobin A1Cs. And the spreadsheets, I couldn't really look at and understand whether we were making a difference. So we started to plot the data. And we started to notice that we were really high, that our average A1C is 9.2. After that, we entered a learning collaborative. We started to read about evidence-based care. I started to read books on measurement and on excellence in healthcare and outside of healthcare. And this was a slow process. So that top blue part, leadership role, I was just barely learning how to do this. And watched as I learned. I was learning with our staff members, sharing what I didn't know, which is about that transparency in leadership. And then getting the right people on the bus. When we started to get our A1C data from the organizational level down to the team level, things really started to get interesting. And I'll talk about later about all the things that occur when teams start to see their own data. But one of the things that occurred for me was I didn't know how to have the conversation with staff. So I was seeing some bad outcomes, and I was not being really supportive and saying, wow, you really need to improve your A1C numbers. These look bad, which is one of those approaches that is not very effective. And then I talked to our medical director and asked him to intervene with the providers and help them improve. That was error number 2 on my part for 2 reasons. One is our medical director at the time was not on the bus. And so you see that third line that says have the right people on the bus. He did not really want to talk to other providers. He did not want to look at data. He really just wanted to do his own thing. So it took me a while to change that position and get a great provider who I have a picture of later who was able to lead that conversation. Another thing we learned in this pathway of measurement and attempts is that we were starting to measure things, and then somebody would be sick and we'd forget to measure, or somebody would leave the organization. We didn't have a person specified to be in charge of data, and I think that's where many of you are, and we learned that that data person is crucial. Somebody who's really smart, doesn't have to be incredible at math, but really gets visits and understands what questions to ask. So our data person noticed that our A1Cs were better on some teams than others and started to look at why that might be. So that's recognizing positive deviance, looking why some groups are doing better, not why some are doing worse. And then we really focused on strong teamwork. And Kate, who you heard speaking at the beginning of this, and the Patient-Centered Primary Care Institute actually had a presentation from Dr. Ron Stock a couple months ago that was excellent on strong teamwork. So I encourage you to find that webinar. And then one of our, I think our brainchilds, and I would encourage any of you on the call to do this, is once we start to measure in various areas of the organization, we started to bring the managers together to talk about what they were learning about measurement and change and how their staff members were doing with the data and where there was fear and where there was movement. And that was a huge turning point for us. Once we started bringing people together, instead of me being the teacher in all these different corners of the organization, change started to happen quickly. And after that, we had run charts everywhere. So I just want to say, be easy on yourself. That was an 8-year journey for me, for us, from the time I first started to learn about measurement. Some of the things I'll share later, the Baldrige criteria and balanced scorecards. It was slow, so one step at a time. This next slide frames aspects of leading a data-driven organization. And so we're still in the framing of how you use data for quality improvement. That on the right side, you see those words Baldrige criteria, and at the end of this slideshow, you'll see the reference to that and how you can hit on that site for those of you that have never heard of Baldrige. Baldrige criteria were developed in 1981, and it's a national education program that's very customer-focused, a change agent orientation that really emphasizes increasing quality and increasing efficiency, which is what we want to do in healthcare. There's a healthcare criteria, but it's really meant for any sector of the economy. And so those 7 areas are what we know we need to focus on to really create a learning organization. But you'll notice there's black outlines around 5 of those, of the hexagons. And that is to let you know that those are all areas where measurement can occur. And interestingly, one thing I really like about this framework is that you see that bottom right one is measurement analysis, and knowledge management is a key aspect of learning and improving organizations. So not only do you measure in these different areas, you also develop an acumen for measuring in general and acting on data. And then on the left side are the key attributes of learning organizations. And one thing we know from a lot of data is staff members and patients align around moving to improve health. If we start to focus on bottom line, moving to improve our bottom line, it's really hard to engage staff or patients in that pursuit. But if we focus on health, the bottom line tends to take care of itself. The alignment alignment I'm going to talk about in just a second. This is about constant learning. Improvement is always change. So it's constant change, and it's how you take care of your staff and yourselves as you get better and better. You heard me reference teams earlier. And staff engagement, that's another area that we know really improves quality outcomes, is to engage our staff as opposed to satisfy them, to truly bring them into the conversation to create constant improvement. So this slide shows is a depiction of drive-down metrics. So the top columns, quality, finance, cost, and customer, and those black words underneath each of those tie to the Baldrige criteria framework. Those are just 3 categories in which measurement can occur. And then as you see on the left side, there's high, medium, and drive down, or where the work occurs. And I call it the low level, but it's really the most important level to me. It's where you can actually make improvement. So if you follow the quality metric down, at the high level, we want to have all hypertensive patients in control. 70% in control is our goal. At the medium level, we want to look at the provider team level. So that would mean we would have panels of patients assigned to provider teams, probably about 1,500 per primary care provider team, plus or minus probably 300. And they would know their patients, and of those 1,500, probably 300 have hypertension. And of those 300, we want 70% of them controlled. So now we've gone to a slightly lower level. People have names, birth dates. So we're starting to think about getting actively involved in improvement. And then we go on down to that lowest level, and we want 100%. So this is how that team's going to act. They want 100% of their hypertensive patients to bring in their medications to the medical visit to demonstrate how they take them. Because we know in hypertension, a lot of people don't take their medications properly and therefore are not in control. So that's the level we want to measure. It doesn't help us to keep measuring the medium level, which we do keep an eye on, if we don't make improvement at that next level. So this slide is just a slightly different view of what I just mentioned. So the highest level is, what do I want to improve? It could be for the whole organization. It could be for a site. It could be for a disease. So in this case, we want to improve hypertension. And at the next level, so you'll see the 1, 2, and 3 triangles on the right. The bottom 3 is where the work occurs, where we can make improvements. Number 2 is what we talked about. It's at the team level. We want people to improve at least 70% of hypertensive patients controlled by. So how good by when is an IHI, Institute for Healthcare Improvement, Don Berwick quote. Soon is not a number. What is it? Soon is better is not a measurement. So our measurement is we want 70% of people to be at 135 over 85 by January 2014. That's the measurement we'd go for unless we were starting at 20% of people in control. If that were the case, we don't want to demoralize our team, so we're going to go for 25%. And then we're going to move to 30% as we get better and better. So now we're going to go to where the work occurs. 70% of patients in my panel will be in control. My panel, our people. Tomorrow we're going to do whatever we're going to do. So in this case, this team is going to call everybody, bring them in. They're going to ask them to bring in their medications if we do that. We're going to check with them after we've given them medications to see that they're using them. So on this slide, these are just 3 different interventions, 3 different theories that the team has to say that we think we will move towards 70% if we do review medications with patients at each visit and ask them to show us how they take them. So that's just one. So when you get to this level of improvement, you've looked at your data, you've decided it's not where you want it to be, and then you start theorizing, guessing what would make it better. And fortunately, there's a lot of evidence in our world now of how to improve hypertension, how to improve diabetes. So we don't have pure guesswork. We can look at the research. We can talk to other clinics. PCPCI has a lot of information online. There's just a lot of information nationally. We can go to learn what are the best ways to improve hypertension control. And then the team can think about what area they want to focus on. So things that allow teams to improve, that really allow for success to occur, because none of this is rocket science, but it's surprisingly challenging. What we in leadership often don't do well is give people time to meet. We're so busy about making sure we see 18 patients a day, or whatever our pressures are, make our bottom line. It's really hard for us to pull people offline to allow them to meet. If we don't allow them to meet, they will never improve, and we will get into a vicious cycle of sort of haranguing people for improvement and not giving them the time to do it. So it's really important that we do that. Ideally, I would say improvement teams would meet at least every 2 weeks. If you were the person working on this improvement in hypertension, like the team, you would probably have a front desk person, you would probably have a clinician, you would have the MA or whatever you have, the RN, you would have your data person sitting at the same table talking about how are we going to do this? Let's have people bring their meds in. Who's in charge of calling? Who's in charge of measuring? So it's a team effort, and it's with the experts at the table, and the experts in this case are the people doing the work. If you're really advanced, and we never did get that advanced on our pathway, you include patients in that conversation. They're part of your team. So, and then focusing on how you improve, and so we're going to look at a slide that talks about the different tools to take the data that you've developed and figure out how to improve it. Bullet number 3, plot data over time. What we know really helps people improve, and impossible, I would say, to do it without it, is plotting data over time. So in this situation, you might plot how many people came in with hypertension on Monday and how many people brought their meds. How many people with hypertension is your denominator? We saw 10. Only 5 brought their meds. So on our run chart, we're going to put a 5 with 50% we're going to put. And then the next day, we're going to do the same thing. How many people came in and how many brought their meds? And we'll do a percentage. And I'll show you some run charts like that. Once you start to look at that, you start to notice how well you're doing with your interventions. And once you get to that bottom bullet, celebrate, 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 what we could do better, I could definitely do better at this, is setting incremental goals. And then when teams achieve them, help them celebrate their own success and help recognize it in front of the organization. And then you want people to copy what they've learned. So Team Y wants to improve. Okay, they believe that if people bring in their medication, they will get better if they get to go over it. Here, these are 2 different tools for improvement. The PDSA, Plan, Do, Study, Act, and that nice little diagram you can find online really easily if you like that, is the plan is to figure out what we think we want to do to intervene. The action is to carry out our plan, the do. So we have our baseline data. We know we're only at 25% of patients bringing in with hypertension control. So we're going to start asking them to bring in their meds. That's our new measurement. Did they bring in their meds or not? So as I mentioned, we'll measure every day who was supposed to bring in their meds and did they come in. At the same time, we're also going to be asking our data person to watch hypertension control and see if it's changing. That's the do. Then we're going to study it again. And if it worked, if our hypothesis is that if people bring in their meds and show us how they take them, they will improve their hypertension control, then we have something to celebrate and share. A3 is another tool. It's a lean tool. Some of you have probably seen it. It's a nice big piece of paper always. And it forces the team to walk through all that they know about the current state, what they think is causing the current state, barriers to improvement, and what their belief is they should be doing to improve it. And then they measure it too. So it's similar. It's just a little bit more detailed in comparison to the PDSA form. And I'm much more familiar with the PDSA. So here's the run chart. Let's pretend that this is the title for this. We're going to say is, let's see, did they bring in their medication? So on day 1, it looks like 55% of patients brought in theirs. On day 2, almost 60. On day 3, a little bit over 80%. And what we're looking at is variability. So every day it's a really different number. And when you're doing quality improvement, there are really 2 goals related to this. One is to decrease variability. We'd like it to be 100% every day. Or 90% perhaps is our goal, or 80% of patients will bring in their medications to review. But we're not getting there. And so then we go back to that PDSA and we go, how come we're not able to get patients to bring in their medications? Well, it turns out only one front desk person knows the dialogue. And when she works, we hit 84%, and then we hit 90%. But when she's not on, the other people haven't been trained how to do that. So then our PDSA ends up being training the front desk how to do this, and then we measure again and see if we've made improvements. One of the big improvement areas that we know about in healthcare is checking in the morning, huddling with your team. So once you've decided to do something like remind people to bring in their medications every day, it's really helpful if the whole team huddles in the morning, thinks about the work they have coming up that day, and also reminds each other that their job is to focus on getting medications brought in and reviewed. Behavior changes is hard for us as it is for our staff members. So. I wanted to put this up there because I think a lot of times we get sort of afraid of the whole idea of run charts and Excel spreadsheets, especially if we're not proficient in that area. So this is a homemade run chart on the wall of Oregon Primary Care Association where I work now. And we do staff engagement. We measure staffing, and we measure it quarterly because we have looked at lots of data that says a highly engaged staff helps the organization offer great services to its customer. So, and what you see there is we have a Likert scale of 1 to 10 on the upright line, which is the y-axis. And across the bottom, we have quarters. We do this every quarter. So you see 7.78, 8.2, 7.9. And then you see those longitudinal lines that run through it, and that's the range. So in quarter 1, which was January through March, it looks like one person in our organization, or at least one person, was at a 3 in terms of their engagement, and at least one person was at a 10. And the average for the 22 people that work here, we were at 7.78. We have said here that we want to be always 8 or greater is our goal. And we established that after figuring out what our baseline was. And then what you see also on this picture is that on either side, there's a question on one side that says, what one thing makes it as high as it is? And we gather that information. It's an open-ended question. And on the other side is what one thing would make it better, would make it rise toward 10. And then we gather that and we share it with the staff transparently. So that's one of the hallmarks of an organization that's a learning organization using data well. It's kind of scary sometimes for management and leadership, is sharing data transparently. So so it's not a good excuse to say I don't know how to use Excel or that my EHR won't produce that report. It's a real reason. They're pain in the rear often with EHRs to get them to do what we want them to do. But this run chart, so run chart is plotting data over time, time down below, and what you want to measure is on your left, was produced by 2 staff members, neither of whom have any training in QI. But they're in charge of our staff engagement data, and they did all of this work. So kudos to them, but it means that all of us, we don't need a big QI background to start producing run charts. You can produce them up front at your front desk, figure out what wait times are. We at my old clinic asked people to chart their staff engagement daily, so they would just put a little sticky on a flip chart piece of paper on the wall. So there's all sorts of ways to do that. Next slide is going to show you about run chart rules. And this is from a line of study called Statistical Process Improvement. And if you get a chance to take the IHI course with Robert Lloyd, and there are probably other courses around, that's just the one I know and that I've sent a lot of people to, and myself as well as I was on my learning. What you see here is 2 run chart rules that are fairly important. So you've plotted your data over time. Let's say we were trying to figure out on this one how to see more patients, how to see about 15 patients a day on rule number 1. So one day 12 came in, one day 10 came in, one day 18 came in, one day 6 came in on those first 4 data points. And that, again, is variability. So how come that's happening? We want to see, we have 16 appointment slots to fill, and we are all over the board. On day 6, I think it is, where you see that circle start, they started a new process. And their new process was to not let the phone ring more than 3 times. I'm just making this up, but those are actually true things that we all know about in our lives. So they wouldn't let, and they had a backup system to phones, so phones did not get dropped. So that was their new, relatively easy intervention. And you see for 6 days in a row, they saw at least 15 patients or more. So run chart rule 1 is that once you implement something, or it could be by accident, but this is, we're going to say this is a purposeful implementation, we know a change occurred. And rule number 1 says if 6 data points are above the median, not the mean, but the median. The median is the centralmost number of a series of numbers. So if it is 6 data points consecutively above the median, a change has occurred. It's not just random variation. So we'd want to understand why that occurred. Ideally, it was something we did. But maybe a new great front desk person started, and she was there every day and really on top of the phones. And then she left the next day, and it started to wander, and then she quit. And then we're back to that lower. And so so that's run chart rule. That's how you know a difference has occurred. And run chart rule number 2 is somewhat similar. You have to have 5 data points either moving upward or downward. So instead of 6 wavering, as in rule number 1, you can get to as low as 5 data points above the median or below the median, but they have to keep moving in one direction. If they start going up and down, then you need to go back to rule number 1 to have 6. And you see that I pasted a link down there that there's really good, if you just do run chart rules, if you want to read this, there's a couple more run chart rules that are a little more kind of picky. These are the 2 most important as you're doing quality improvement. So this is sort of a joke slide. It's what happens when you start showing data to staff members, probably to us too in leadership if you're a leadership person. First, we're shocked that we are often that bad. We thought we were immunizing all children, but in fact we're only immunizing 40% fully, which is true in a lot of the places I work. Then we're in denial. This cannot be right. Somebody collected the data wrong. Then we're angry because my team's not doing this poorly. So it must be George across the hall and Mary down the hall and their teams, because we are much better than that. And then we say, well, you know, our patients are different here because they actually don't like immunizations. They are really opposed to them. They are non-compliant, one of those words I really dislike. And then finally we go, dang, I guess this is really data about us. What I will say about that, stages of data grief, you probably know stages of grief, and this is sort of a play on that. This is true. It really happens for us. It really happens for clinical teams. And I think the most important thing I learned in my pathway is listen to the concern. It is about wanting patients to be healthy, and it's also about wanting to do a good job. Data is often not clean. That is always the first step in using data is it actually good data? And almost always it's not that good. So usually it can be improved upon. And then once you get to data is just good enough, which is probably where you should aim. Don't go for perfect because you'll never get there. But it's really good enough data. It's pretty plausible, pretty clean. Then it's helping provider teams navigate toward improvement, is getting away from blaming, believing the data, improving the data so that they can believe it, showing them how the data is generated. In our organization, we gave ourselves 6 months to have that conversation about this data is just wrong. And at 6 months, we kind of said, okay, we've made it better. It's pretty clean. We're going to use it. So it's sort of a joke slide, but it's the truth that we all live with. The reason, so now we're moving into the culture of what, when you start using data, start putting run charts around, you start to notice people have funny responses to them. Some people really love this stuff. I bet about 10% of our staff members, probably 60% find it just fine. And another, 30% are really bothered by it. And so some of the things that happen when you start to show data like this is there's a fear response. And there's a great article called the Neurophysiology of Leadership. And it shows that all of us experience fear and have a cortisol release, that stress hormone, when we are presented with needing to change. So those of us in leadership often are asking other people to change. And I think if we were asked to change, we would have that same response. There's blaming, there's pushback. I think most of you who've tried this have experienced that. One of the best ways to deal with that is to put data on the table and let open conversations occur, including what bothers you about this, what would you rather measure. We did a lot of provider engagement measures in combination with productivity measures, because productivity typically is a bad word. And looking at provider satisfaction, providers getting home to dinner on time, those types of sort of subjective measures ended up being very popular in combination with asking for higher levels of efficiency. Organizations, all of us, experience competing priorities, so thinking about what you can actually move, what kind of data bits you can move. Start, as I said, over and over, tiny, small, and succeed. Don't let go of it. Or don't start at all right now if things are too crazy. If leadership's changing and EHRs are changing, wait a couple months till things calm down. And then gimmicks tend to backfire. So, you know, we hear a lot about provider incentives, incentives to improve quality metrics, incentives to see more patients. I really don't like those and have a lot of articles that would tell you why you shouldn't do them. But if you like them, you can probably find as many articles that would say that it's okay to use them. What I would say in the PCMH world, in the PCPCH world, patient-centered primary care home, it really makes no sense to me to incent one provider who is just one team member. If you're going to do incentives, and this is very complicated, incent the whole team. And it's a pain in the rear once you start doing that, because it's a tricky math and what are you incenting. But I really discourage singling out one person on a team when we're talking about team-based care as though they are the most important person, because all team members are equally important in patient-centered care with patient at the center of that. So this is just a cute little slide. I like the clip art, but this is, again, the movement into the culture of change. And you can have great strategy and great data, and if you don't create a culture that embraces improvement and makes it safe to look at data, you'll have a very tough time moving. Sorry. So cultural, it's something we talk about a lot, and I don't think we really understand how to change it in our organizations. But just briefly, I'm just going to pull out a few things from this slide. What an organization's culture is are the values, norms, and beliefs that live within that organization, often well supported by leadership. So whether they are good or bad norms, they are pretty fixed. And having worked in the organization I used to work in and having 4 different sites, it was intriguing to me to watch the norms that existed differently at different sites and how hard it was to change some of the belief systems in one site in particular. Often they are not explicit, meaning we don't articulate what our values and norms are. And if you haven't done that, I really encourage you to do that, including that we want to have improved health for all, and that we believe in using data toward that effort, that we believe in supporting staff to do improvement. And then that cloud little bubble below is just a warning to me and all of us is to avoid culture killers. And the killers are the contradictions. So when we say we really believe in change, and we really believe in looking at data, and we really believe in focusing on systems, not people and individuals, and then we single out an individual and embarrass them or cause them to feel at risk, we lose so much credibility. So it's walking the walk and using data in a way that really, really motivates. And I used to give a talk called Measures That Motivate. So think about things that we want to do, which is improve the health of the people we serve and to love our jobs and for patients to enjoy coming to us. And if we focus on those things, people tend to just jump on board. And if you make a mistake, which you will, I did, I made plenty, it's learning how to apologize, which is never that easy. So keys to culture of improvement. The picture on the left is my former medical director, and he was the right guy on the bus from that earlier slide. All of a sudden, when he became our medical director and started leading by example, absolutely, always pushing his team gently to improve health outcomes in the population, his panel. And then this site, and I'm happy to share this after the call, we had run charts for every single team, about 8 of them. And they saw them monthly. So they saw their diabetes and hypertension and visits per day. And I don't think they saw staff engagement by team, saw depression. So they each saw everybody's, and I think there were 12 provider teams when I left, every month. And then they would talk about why some people had such great outcomes, and they'd start picking their brains about what do you think is causing your diabetics to get better A1Cs than mine. So that's, again, called recognizing positive deviance versus the opposite. So you don't want people to be fearful. That's one of the things here. It says drive fear out. That is a huge quality. I don't know if you guys have heard of Edward Deming. Driving fear out of organizations is imperative. Focusing on systems, not people, and recognizing accomplishments. And it can be small. It can be in your morning huddle. You guys clap because you succeeded. Okay, let's move on. So this I did because sometimes people say, we just need specifics. So this is sort of a silly thing, but remember Goofus and Gallant from Highlights magazine? You have to be old enough to know what that was. It's not an online magazine. So Gallant and Goofus, Goofus was always making mistakes, and Gallant was always doing everything perfectly, kind of the Eddie Haskell of Leave It to Beaver. So when you're doing quality improvement and looking at data, here's how you would want to do it. Wow, look at that run chart. That is so beautiful. Can you tell me about it? What system changes did you make? This is incredible. What are you thinking will be your next steps? Would you be willing to share that at our next mini measurement summit? So think about the excitement and how people feel so proud of their efforts. And then on the other side, Goofus, the screw-up, says, geez, how come you are so far behind Team Y? What are you guys doing wrong? You have a problem. You, not the system, but you personally have a problem. You better talk to Team X because they're way ahead of you. This is not acceptable. You need to work harder. We're going to plan to tie pay to improvements, and when that happens, you are not going to be doing well. So can't you just feel the energy drain out of your body and the embarrassment, and you just feel like, I want a new job? So those are it's simple but really true, and we all have found ourselves on one side or the other. So just to reiterate, setting things up for success, invest up front. I want to remind you, not plugging other webinars, but I really enjoyed Dr. Romstock's webinar, and I have done a lot of work on teamwork too, so you can write to me if you want some samples and some ways to evaluate. But help your teams get together, help them form, help them think about what they're trying to do, and then give them time to meet at least biweekly. Teams, I've noticed in a lot of places they have a data team, and then they have the QI team, and then they have the provider team. Those should all be one group of people working on an improvement. There's a little proverb here, and it says, an old proverb, a wise man coming across a guy sawing a log with a dull blade. He says, if you take 5 minutes to sharpen that blade, you'll saw 5 times faster. Nope, says the guy. I got no time for that. I got to keep working. So you get the gist of it. The time is to take time out to improve. Mark Murray, who's an expert in access and redesign, used to say, you know, football teams practice for 40 hours a week and they play for 2 hours a week. So practice for 40 hours a week, see patients, in other words, for 2 hours. And they're really good when they're seeing patients for 2 hours. The rest of us see patients for 40 hours a week and never take time to practice. So think about how to change that just a little bit, and I think you will notice that when you pull people offline, they become more efficient and effective so that when you put them back on, you really have only gained and not lost. And then as a reminder, you want teams to have a feeling of group self-efficacy. That means a feeling of can do. I can do this. We can do this. We are smart, and look what we just did. We just improved our med list. Now let's go for the next thing. So help them start small with really reasonable, achievable goals. That is really very important in the beginning. As I mentioned in the early slides, think about where you are now and don't, if you have way too many things happening, then just let this sit until you have one less thing happening. If you don't have way too many things happening, think of a small thing your team can take on that you believe they will succeed in. And set it up, you know, put a sticky paper on the wall and do markers for your run chart. If you don't feel like using Excel or pulling something off your EHR, ask teams what they'd like to measure. Ask them what's in their way. You know, very often it's the room is not stocked properly. So let's measure how many times the provider has to leave the room to find something. And let's get that better. Let's measure how much time patients are waiting in the front area. That's not an it can't be EHR, but it doesn't have to be. Let's measure if we're huddling every day. So these are all things you can do on the wall, and people they all start to become experts at measurement as you apply it to something that's important to them. That's something in the way of them doing the work they really enjoy. And if the culture, you know, feels unsafe for improvement, start to role model the opposite. Even if you're not the leader, start to create your little culture within your culture where you can put a run chart up and you guys can make improvements and you can celebrate, and that's, you know, called managing up, teaching other people how they could copy you and be really positive about it. Sorry, I'm advancing. It's just a little slow. Or maybe I'm slow. Sheet, I don't think it's moving now.
It just moved forward a couple, so.
Oh, I'm not seeing it. That's interesting. Oh, there we go.
We're on the
okay.
side now. Okay,
on the Mission Impossible one. So this is just a joke, but it really is to encourage you to start where you are and take one small step. If run charts baffle you, just think of something really little, something to measure every day on the wall, something to measure every week. What we do know is the data has to be actionable, and that means that it has to be measured in a time frame that people remember what happened. So if you start to get out to quarterly measurements, it's usually not actionable. It has to be monthly or less. And I kind of like monthly, weekly, or daily, depending on what you're measuring. This last slide has just some of the resources I mentioned. So Good to Great is a really good read. Hardwiring Excellence goes over a lot of the things I just covered. That little Baldrige thing off to the right is the Baldrige website that talks about the 7 different areas to focus on in terms of creating improvement. And then the Interactive Institute for Social Change is a facilitative leadership, great 3-day training. There are a lot of probably great trainings. That's just one I know well that helped us create a culture that fostered learning. And then the Lean is the link to the A3 information. And you'll see QCore and the PCPCI links there as well. So with that, I will open it up to questions. Or Kate will open it up.
So this is Kate. We have a few questions that came in. If there are additional ones, we'll see how many we can get to in the rest of the time we have together today. So the first one was about how you measure staff engagement, and what if there are specific survey questions, or how you can measure administrative staff engagement as well as clinical. Can you speak to that a little bit?
Yeah, I love that question. I'm glad you're thinking. So that's just one area of QI, right? One data QI thing that we know is actually a driver to a lot of the other QI stuff. There are a number of tools out there. There's a Gallup, I think it's called the Gallup 12, so if you search that, you'll find it. I'm happy to send out a compilation that we put together. That's a couple different tools that are out there. We have in Oregon 31 community health centers, and a good half of them are now measuring staff engagement on a regular basis. And then the tool that I was showing you is actually one that I developed at our old health center, and it's not validated, but it seems good, good enough. And that is, we ask people how engaged they are. We actually ask the organization here at OPCA, we asked them to define engagement. So the staff defined what engagement meant. We kind of compared it to what we thought satisfaction meant. Then we measured our own engagement. And then we used those two questions, and those questions come out of the motivational interviewing world. So what one thing causes it to be that high? Even if you're a 3 on a scale of 1 to 10, how come you're not a 1? And then the other one is more the sort of negative side, as what one thing would move you toward 10? So that was our own tool. And we created on SurveyMonkey so that people turn it in anonymously, and then we have one of our staff people, as I mentioned, who's not trained in QI at all, compiles it, and then we do bar graphs on it. We just did, Baldrige also has a great survey called Are We Making Progress? And I love it. We did it for years in my clinic, and so, or the clinic I worked in. So you ask all the staff 26 questions, and you ask all the leaders 26 questions, and you compare what the staff says first. You notice where they think you're weak and where you aren't, and then you notice how leaders and staff perceive the world differently as to how well we're running the organization. And it really looks at barriers in the way of staff doing good work, and if the staff has measures to improve the care they deliver. So you'll find that on the Baldrige site, and just search, Are We Making Progress? And whoever asked that, feel free to write to me afterwards, and I'm happy to send you more resources.
Yeah, and Lori, this is Kate. If there's anything that I can get and then post to the little module where this webinar is posted on the site.
Yeah, I'll just send them to you, and then people can go there.
Perfect, yeah, because everyone who listened to the webinar today and everyone who signed up but couldn't make it will get a link from GoToWebinar in the next couple of days, and that link will have a recording of today's webinar, the slides, and then we'll post all the links that that we can to the resources Lori mentioned.
Oh, and the other question is, we asked, I think somebody asked if you compare providers to staff, and you can do that, and then you have to just be transparent and let the staff members know that you're going to code it, so either you're not a provider or you are. We looked at different sites, and we never looked at providers specifically because we thought they were part of the staff, but there's different philosophies on that, so you can code it, just don't do it secretly.
So then there was another question about challenges with physicians getting buy-in. Do you have any go-to references for physicians that are written by physicians that can provide credibility needed to get buy-in from them and help them get on the bus, something that would motivate them in the direction to go?
Yeah, that's the big $20,000 question, isn't it? If you're in Oregon, I know there's some physicians. I don't want to mention names, but there's the best way is to have one of your physicians who is respected, whether he or she is an informal or formal leader, doesn't really matter, but hopefully people respect that person, and figure out a really safe, low-level start to sharing data. So again, you're trying to foster safety. So maybe it is, visits per day is probably not safe. People hate that measure. It's probably after visit summaries completed, something like that, that doesn't have a lot of emotion around it. And what you do, generally when you start sharing data, is you send it, let's say you have 6 teams, you send it blinded, you send team 1, Dr. Johnson, sees Dr. Johnson's data, and then he sees team 2, 3, 4, 5, and 6 data, but he doesn't know who those are. And then you have this conversation of when are we ready to unblind that, which is what we've done here with health centers as well. when are you ready? And you keep saying, oh, well, that we could share transparently, because one person actually is doing after visit summaries great, and I kind of want to know who that is. And so you just, and ideally, I mean, what I showed you, that picture of the guy, Mark, he made my life go from night to day. I formerly had a medical director who didn't really ascribe to any of this, and what my job was in the end was to remove him, but it took me forever to figure that out. Once I had a medical director who really cared about improvement and really had such a small ego, all of a sudden the conversation changed.
Excellent. So there have been a lot of questions, so we'll see. There was one about how do you suggest that a data guru and a completely non-data person find a middle ground to communicate? Oftentimes we see it as though people are speaking completely different languages and then they get angry with one another. So can you speak to that?
Okay, that's another great question. You guys are obviously living this. I lived that same thing. That's a good question. So let's think about that. It is a different language. What we want to move to that probably next level is, what's our goal? Our goal is to improve care. And we each have different expertises, so we know we want different expertises at the table. And often we say that, but we really don't mean it, because it irritates us when people don't agree. And so one of the things that I think Ron Stock talked about, and that I also have, and Kate, I'll send you this stuff since I keep referencing, is how to set the goals of that team. The goal of the team is to improve your A1C, or is it to create quality metrics, or it's to improve staff engagement, whatever it is. And then what's the role of each member of the team, and what are your team agreements? So team agreements, and each team can reform. This is a team about staff engagement. This is one about A1Cs. Is our agreement is we treat each other with respect, and we use reflective listening to understand what the other person's saying. So very often if you say, what's our goal? Oh, good, we have the same goal. We just don't understand each other. What are you saying? Oh, so what I hear you saying is this, and here's what I'm saying. Can you repeat back what I just said? So let's see how we can use the best of both of those to create a better product. And one of the things in QI I learned to really dislike is two things. Is one, I really dislike the word compliance because it's about somebody doing what we want them to do. And the other is staff buy-in. I don't like that. Is equally bad to me because it's actually not about staff buy-in. It's actually getting staff members' ideas. So when you have these two people sitting at the table that have different ideas, how do you get the best out of both of them and sort of honor their contribution, and you need both. So it's really about a better product. I know it's harder than I make it sound because I've lived it too, but. And sometimes you need a different person. If people are really antagonistic and can't sit at the table, then they aren't going to be able to sit at the table.
So then we probably have time for, I'm guessing, one more question, and these are all good ones. How do you define the difference between celebrating a positive change versus an incentive?
That's a good question. You guys are so smart. How I define is significantly different, but I get the question. So an incentive typically, yeah, maybe that's an even better question I'm thinking. Incentive is typically, when I meant it there, comes out of a lot of leadership research. If you've looked on YouTube at the Drive video too, Daniel Pink is an excellent video, I think 8 minutes, and I can send that to you too, Kate, about human motivation. And when you're motivating really sort of high-level behavior change like provider teams that requires intellectual kind of consideration, monetary incentives, unless they're low and fun, then go for it. Like we did pizza parties a lot. First team to get to X. Or better, I would say better than that, is all teams that get to X get a pizza party. All teams that hit med list accurate or something like that by the end of this month, we're going to celebrate. And all teams that get it the following month, we're going to celebrate, because behavior change on the part of us and patients takes about 3 months to ensure that it's going to be sustained. So that's a fun incentive. I'm talking about the huge, which I see really often and really drive me crazy, is, if Dr. X sees 18 patients per day, often is the incentive. It's usually not a quality one. He or she is going to make an extra $20,000, but Dr. X's MA and front desk person aren't making any extra. And I think that really inhibits team functioning significantly. Not positive I'm right about that, but that was my intuition.
Excellent. So we are right touching 1 o'clock here. So like we said, we'll make sure to get as many of the resources, links, things that Lori's mentioned today and get those posted on the page for the webinar so that everyone can have access to those. There is a short survey after this webinar that will give you the chance to give us some feedback. We'd really love your feedback on the webinar today. And then again, you'll get an email alerting you when the slides are posted to the Institute website. So thank you so much to Lori for her sharing her wisdom and experience with us today, and we'll see you all later.
Thanks, everybody. See you, Kate.
Bye.
The organizer has ended the session, and this